Recording in progress. Hello and welcome, everyone. My name is Renee Garrett, and I'm your Speech Therapy PD podcast host for Brainstorms, Functional Neuro Rehab for SLPs. Before we get started, we have a few items to alert you to. Each episode is 60 minutes and will be offered for zero point 0.1 ASHA CEU. If you're joining us for this live episode and your state license requires live CEUs, be sure to complete all course modules, including the one that says Complete Course, before the end of the day on your Speech Therapy PD account. Here are the financial and non-financial disclosures. Tiffani Wallace receives royalties from Plural Publishing for the Adult Dysphagia Pocket Guide, Neuroanatomy to Clinical Practice from Tactus Therapy for the Dysphagia Therapy app, and Northern Speech Services for the Cranial Nerve Examination, integrating assessment and treatment in dysphagia management. She also receives an honorarium from SpeechTherapyPD for participating as a podcast guest. Her non-financial disclosure is that she created 2 apps from Smarty Ears, Dysphagia to Go and Ice Cream Aphasia, from which she receives no royalties currently, and she writes the blog Dysphagia Ramblings, which also does not receive royalties. My financial disclosure is that I'm the owner and founder of BrainBridge Connect, LLC, and as the host of Brainstorms, Functional Neuro Rehab for SLPs, and other webinars on Speech Therapy PD, I do receive financial compensation. I'm also an adjunct instructor for both James Madison University and Old Dominion University. My non-financial disclosure is that I'm the secretary for the Communication Disorders Foundation of Virginia. Questions can be written in the chat or the Q&A box and will be answered at the end of the presentation. And now we welcome our guest tonight, Tiffani Wallace MA, CCC-SLP, BCS-S. Tiffani resides and works in Indiana with her 2 children, and in her off time from being a home health speech language pathologist and writing her blog, Dysphagia Ramblings, along with sharing content on Instagram, she's running to football, wrestling, baseball, and visiting her daughter in college, which usually means dinner, soda bar, and Target. Tiffani has specialized in dysphagia for over 20 years, authoring the apps Dysphagia to Go, Ice Cream Aphasia, and Dysphagia Therapy, and has presented many courses. She's the co-author of the book, The Adult Dysphagia Pocket Guide, Neuroanatomy to Clinical Practice. The second edition is currently in the works. Tiffani has recently experienced work and life burnout and has been researching and learning all she can about burnout, the symptoms, and how to overcome it. Tiffani, so great to see you and welcome to the podcast. We're grateful to have you.
Thank you for having me. I appreciate this.
Yeah, one of the questions that I usually jump right into, and I hope you're kind of off cuff, and I hope you're okay with it, is I like to ask people their why of why they got into the field of communication sciences and disorders, because I think, there's a kind of assumption that people just learned about it in school and they don't have a personal connection. But do you have a story to share or a why you became a speech language pathologist?
So for me, we did a career day at school. And so I shadowed our speech pathologist there. I think I was a sophomore in high school. And so my dream was to be a speech pathologist that worked in the school systems. And so I did a little bit in the school systems and decided that that was not for me. And so I've done medical ever since. I love the medical part and I love my adults. So
yeah, no, medical's always been my thing, and I think I always knew that I wanted to work with adults, but I did have such a great pediatric outpatient experience in my clinicals that I would have entertained. I mean, I did interview and got offered a job. Just, when you're going for your CF, you're just trying to get a job, right? You got to get your foot in the door somewhere. And I think for a lot of us, that's kind of how it started. And, but yeah, so thank you for sharing that.
Yes. I think the most ironic part for me was I was absolutely disgusted by dysphagia. I I wanted no part of it. I was never going to do it. and it has become my passion. So
That is so funny because yes, that I say that all the time that was I did well in the course. We had a dysphagia course and I did well in it. And I actually had a great instructor and we did part of our coursework was MBS and like watching them and detecting aspiration or not. Because, back then that was kind of the only thing you really needed to know was did they aspirate or not. But she did really require us to know the anatomy and physiology too, which is helpful later. But I was like, this is not what I want to do. And I went to inpatient rehab and then wound up in acute care. And literally that's what I did. It's so funny. That's so
yes,
funny.
yeah, I started in the age of DPNS when everybody was doing that.
Mm-hmm.
And I have never been more turned off by something in my entire life. So I'm glad that has disappeared from our universe and I don't have to do that anymore.
Well, it's so funny. I was looking at something that you posted today about K and G words, and I started laughing. I was like, oh my God, how many times did I give those sheets for home exercise practice to my patients,
Yeah.
15 plus years ago? So I felt that in my soul.
Yes. Absolutely.
So let's jump into burnout. And, we're talking about working in the healthcare atmosphere. And is there something specific that you wanted to talk about as far as like just the workload, the caseload, and how all that leads to burnout, or just let's talk about the environment in general.
Yeah. I know for me personally, um, it was around 2021, I started experiencing burnout myself severely to the point that I could not function. I was just so completely burnt out with everything, which it was, just past the whole COVID-19 pandemic. I had a lot of things going on personally with my own health, my personal life, and everything. So it was something that I didn't realize was happening, and I never really knew the symptoms. So I started really researching burnout, which, if you know me, I get very passionate about something I go through myself. So I started reading this, and I think I see burnout in more people than we realize have it. But there is a way to avoid it. There's a way to climb out from it, and so I think just learning how to realize that that is what you're experiencing, to figure out what causes the burnout, and to figure out what you can do to get away from it is huge. So
Mm-hmm.
that's kind of what I've been really researching.
Yeah, and I think a lot of us did, working in the hospital during, I was working in acute care during the pandemic, and
Mhm.
I can certainly see how a lot of people were already on the train, right? They were already on that progress train to burnout just because of productivity requirements. A lot of hospitals locally for me had one or two SLPs, which now they have five or six, which makes me just giggle. It's great
Mhm.
that they have five or six, but like when I'm telling you I need help and we have one or two people working in this environment, it's really challenging. And uh, I think it really does speak to, though, crossing over to educational settings where school system based SLPs are typically covering one, two, three schools. They're the only
Mhm.
one. They're seeing 60 plus kids a week. It's insane, the expectation. And um, I don't think it's unique to medical. I think it's definitely something that we are becoming more vocal about across the board and across practice settings. But talk to us about what those symptoms look like. Like, how does it sort of start where you feel like you're spiraling, but you don't really know that's what it is? Because hindsight's 2020,
Yeah.
right? We look back now and we're like, oh, I should
Right.
have seen this coming.
That's what that was.
Yeah.
Yes. So you can have a lot of issues can cause that burnout. We have, like you said, the workload, the caseload. So many of us are the only SLP within 100 miles, and we're covering any place and every place that is there. We have our documentation on clinical tasks, our meetings that will contribute to burnout. I know I work in home health primarily, and the number of meetings that they expect us to be on is ridiculous. I can't possibly do that and do my day too. And we're constantly, as I think, especially in the medical field, we're always exposed to grief and depression and suffering. We see these families who, go through a lot as a new caregiver or as a burnout caregiver. We see that often. A lot of times in our own workplace, we that can contribute, just the understaffing, the expectation that we can see 450 people in a week and we can't do it. Expecting us to document on our own time, expecting us to be 98% productive. Those are all huge impacts on what we're doing. Some of the signs that you might see in yourself is you wake up tired. So no matter how long you sleep at night, you're still exhausted. You stop finding joy in the things that you used to love. You might be very irritable. You might be very anxious, but you have no explanation for it. You keep getting sick. People that are just constantly sick or constantly taking medicine, constantly taking time off, that can be burnout. You may just feel emotionally numb at that point. You may not really feel any kind of emotions. It's those of us really caffeine, sugar, sometimes alcohol, just to get us through the day. I know
Yeah.
definitely for me, it's caffeine. You may start to find yourself zoning out at work and not really paying attention. You may notice that your motivation is gone. You dread going into work every single day. Those people that you might see them post on social media on Sunday, like, ugh, it's Monday tomorrow, got to go back to work.
That
And
was
you can
me.
relate to that. You start to, yeah, yes. And I fight that every day of my life, not having that attitude.
Hmm.
And you sit there like, what is wrong with me? What is going on with me? I am not myself and burn out. So, and those are just in the research, and there is quite a bit of research about healthcare. Most of it is more geared towards doctors and nurses, but I
Hmm.
do feel like we feel a lot of that same impact as what they would
Oh,
feel.
yeah. I remember my end of the time I was working in acute care, I'd been there for well over 10 years. It was like, and I was
Mm-hmm.
the only one, and I was actually flexi, so they used me like I was part-time, but I was flexi. Um,
Mm-hmm.
and I just remembered like I would drive, especially towards the end of the pandemic, it was like I'm driving into work and I'm like, why am I doing this? Why am I doing this? I have to be there for my patients. I have to be there for my patients. It's like you had to self-talk all the way
Mm-hmm.
to work. And my commute went from
Mm-hmm.
28 minutes to 17 because no one else was working. It was just me driving to the hospital. And so that part was great because I had a 10-minute or 11-minute
Yeah.
less commute. But at the same time, it was really challenging to, talk myself up for something that I knew was just not fulfilling me and not bringing me joy anymore. And not to say that the patients weren't
Right.
bringing me joy. It wasn't and that's the thing that's hard, I think, for people to understand who aren't in our field or aren't in healthcare or schools, is that it's really never the patients or the clients. It's always the challenges of bureaucracy and admin and like meeting those expectations that are set by people who have never been clinical, who've never worked in the
Mm-hmm.
ways that we work. And that part is the hard part because every time we think we have a system and a routine and we can, okay, I've gotten into this mode of I'm going in, I know I've got to do this, and I've got the system set up. So I'm doing chart review. I have this many minutes. I have to do this, and then I have
Mhm.
outpatient MBSs, then I have my inpatient MBSs. I maybe have a few fees to do, and um, and now we're just trying to figure out someone's throwing a monkey wrench in that system. I think we might have lost Tiffani for a second. So um we'll keep going. Yeah, I think we tend to just muddle through. And that's again, that's a huge risk for burnout because we're looking at safety concerns when we're on autopilot. We're getting in this routine and we're trying really hard to have this routine um, so that we can make our day as smooth as possible. And then we have someone throw something else in. You've got to go do this rounds, or you've got to go do this, and this counts against your productivity, or you have a staff meeting, or you have a vendor coming, or whatever the case may be. And I think that's the hard part. That's the challenging part.
Mhm. And I feel like, and I know that occupational do, or so many patients in the hotel, they're being told how they're being due side the clinical swallow evaluation to do that in 30 minutes. It just cannot be done in 30 minutes. I feel like, especially as we feel so
I think we are having some technical difficulties, but I think what Tiffani was saying was that, it's really hard to complete these evaluations in these short time frames that we're given, especially when it comes to instrumental exams or clinical swallow evaluations and just having these time constraints of getting all of these done in such a short amount of time. And we're having some really good comments. Um, yeah, someone said it's not the therapy, it's everything else, and feeling like you can never get it all done. And each day you feel like you fail even though you work so hard. Yeah, I totally agree with that. Um, and Tiffani, if we brought you back, you're breaking up really badly for the guest and I'm just letting you know, it's breaking up pretty badly. Um, but we're talking about the same thing you and I were talking about was that it's really hard because all of us want to do a good job. We want to make sure our patients are taken care of and our clients are taken care of, and systematically, some of these systems that are in place, some of the um, changes that happen when it comes to documentation or time constraints for therapy are really just a huge barrier for us. Tiffani, I think you might be back, but I'm not 100%. So we were hearing you and then we weren't hearing you. So I think Tiffani is disconnected and trying to come back on, but I'll just kind of read through the comments. Someone said they worked in the schools and always thought medical setting SLPs had more control over their schedules. So that was interesting to hear. Yeah, we kind of do, but I know when I left acute care, it was becoming more, used to we would triage patients and we would try to work around our outpatient instrumentals, as far as modified barium swallows. And if you're doing fees, we had outpatients who would come in who were like a one-time visit with us. And so what would happen is we would try to triage our patients and look and see who the acute strokes were, who's in ICU. We try to get there after rounds, just in case any new orders popped up. And you're trying to go to the people who are MPO obviously first and try to get them scheduled for an instrumental if that was uh, the flow. And then by the time I left acute care, it was coming to the point where we were being allotted a certain amount of hours for new evaluations. And then it was the expectation that you would go do follow-ups on patients who were getting close to discharge. And then you would have your outpatient instrumentals, and then you would go back and do evals if you could. That's it was dictated by a regional manager, and it wasn't flowing, it wasn't effective, at least for me. And it was a real challenge because I felt like my clinical judgment and my clinical autonomy were being constantly judged. And so one of the comments was that it was unrealistic expectations, and I would say 100%. I felt that way on a lot of days. I felt like the expectations for how the day would flow when it became out of my control, and the productivity expectations were just nuts. Hi. And now we don't hear you, Tiffani.
Thank-
Oh, there you are.
I am so sorry about that. I don't know what's going on.
It's okay.
And it
I was
just
reading through the
sometimes
comments of mostly the overarching theme is that expectations are typically just unrealistic across settings.
absolutely. Um, I remember it, like I said, I work in home health apparently, and regional director came in from meeting. I think very great.
So we did have someone else who said they have experience in both settings and found they have similar issues. While you need to be productive, but there's so much documentation and so many meetings, and it was hard to, really coordinate all that. And I know it's funny because I told my husband today he was having an issue at work, not really an issue, but like a discussion at work, and I was just saying to him, the same thing was that, I never felt like when I was in acute care, PT and OT had their own space, and we had this like off branch office from the outpatient and cardiac rehab clinic downstairs, and that's where my office was. And so I really didn't feel like I ever belonged in the PT and OT gym space. Not for anything that they did, but like their flow was different than mine. They all had laptops on carts. They had like four computers, whereas I had my own. desktop office space downstairs. And so it was a really weird. When I was PRN, it was cool because I was the only one there. No one cared, right? But then when I became more of a permanent part of the staff, it was just a weird flow sometimes to not always be um, in sync with the rest of our department. It was just kind of a weird flow.
Okay, I'm going to try this on my phone instead.
There we go. Thank you.
Okay.
Welcome back.
All right.
I've been
I'm
trying
sorry
to fill in the
about
gaps, so hopefully I didn't
that.
mess it
No,
up too much.
any other time my Wi-Fi is perfectly fine. Tonight it's just going to be not cooperative.
Yeah, I mean, that's fair.
Yes.
Um, so
I don't know.
what I've kind of been filling in the gaps on was just that people are, in the comments are just saying that there's some people who have worked in both schools and healthcare and just found that red tape, documentation, meetings,
Mhm.
all the things, productivity, are just really don't set us up for success. And we all want to do well and be good at our jobs and do the best we can for our patients, but we're in this weird space of like, how do I make all that work?
Yeah, we are. And we ended up getting um expectations that our documentation has to be done by midnight of the same day. We now have one-on-one meetings every week that they track our numbers of how high of a percentage our documentation is done within so many minutes of our visit ending. Like it gets to the point of being ridiculous, and our staff turnover is just ridiculously high.
Mm-hmm.
So,
Yeah. That's what I experienced in outpatient, and the expectation was um, they wanted us to do point of service, and I said, well, we can't because that's not part of our billing code.
mhm,
And our regional manager, and our VP were all PTs who were used to everybody doing point of service documentation, and I'm like, well, technically, we're not supposed to do that in outpatient, definitely not in
mhm,
acute care. And also, I'm not taking my laptop home because I'm hourly, I'm not salaried,
mhm.
and I'm not working off the clock because that's illegal and also unethical. So
Absolutely.
you can imagine the HR nightmare that I became. I was that girl.
Oh,
Yes.
yes. I am that same person.
Well, I think it's important because it's unfortunate that we have to advocate for ourselves to that level when most of us are so staunchly trying to advocate for our patients because we know that access to service for them and ongoing care is bad. It's dictated a lot by insurance, and
Mhm.
um, I just was telling someone the other day with TBI patients now, a lot of times when it's a COG-COM TBI patient, it's like you get 4 visits.
Yeah.
Four visits to outpatient. I'm like, I'm good, but I'm not. No one's that good.
No.
No one's that good. Like we can't get these patients back, and whether it's a student athlete in college or
Mhm.
someone who's in the lifespan of work age, it's very challenging, and I think that's where we start to take things more personally, and we're like thinking about it when we're at home. We're thinking about how can we problem solve through this and make this better for our patients, but that trickles over into our personal lives when we're
Oh,
not able to leave it at work because it's hard to do that.
yes. And I feel like our jobs are so hard because, you go home and you're like, oh, I wonder how Sue's doing. She wasn't doing very well. And, you start talking about, family members that were so mean to you or family members that are just so sweet to you. And, you do have to draw that boundary because otherwise you're constantly on and you never get that off time.
Yeah, and then we take on students, we take on CFs, which is great because I love to mentor people, but
Mhm.
that's a whole other challenge because we're already in this space of burnt a little bit, and then we're taking on this other person who we're trying to mentor, and we're not always able to teach them how to set those boundaries. And because
Right.
we're telling them one thing, but we're doing something else because that's how we're trying to muddle through and make everything work. And I think that's another challenge is how do we deal with that when it comes to, our clinical instructed students and then our CFs who we mentor.
Mm-hmm.
So, have you also had that experience?
In home health, I don't get it quite as much. Being in such a small area that I think I've had one student. I do have to end up training a lot of our SLPs from other areas in the
Mhm.
state. They usually come and follow me. And, sometimes that can be challenging because you want to paint the job in a really good light, but some days you just don't feel that way. So you really try not to get into the ins and outs of everything that happens, but it's really tough. It is really tough. I've definitely had to start setting my own boundaries. I was to a point that I was getting messages on my personal phone from the office staff. I'd be on vacation, I'd be out of state, and they were wanting me to log in and do something. And I just finally told them, hey, if you're not going to do this on your vacation, I'm not doing it on mine. And I will not respond to them. Everything is to go through my work phone if it's work, and I turn it off when I'm not working. And I tell all my patients that you can reach me during work hours, and that's it.
Mhm. Yeah, and I think
So,
that's great because that's how it
yeah,
should be. And the other part of that is, um, one, we're not 24 hours on call.
no.
Two, we deserve some time and space to ourselves so that we can decompress these things that are challenging, that are, we and again, this is, I think, overarching in schools and healthcare. We deal with a
Absolutely.
lot of really hard cases from, end of life cases to poor prognosis to kids with, and teens and young adults with disabilities that will, make it so that they have to be dependent on a caregiver for the entirety of their lifespan.
Hmm.
And sometimes that's a heavy space to be in, especially.
Hmm.
I feel like kind of came like in acute care, it kind of, I don't know, went back and forth. You'd have these really heavy seasons, and then sometimes it wasn't as complex and maybe not as heavy on a consistent basis. But around the holidays, um,
Hmm.
here I'm in, the coast of Virginia, we have a lot of tourists who come here. And sometimes when I was working in the acute care that was the bigger trauma hospital, we'd have people who came here on vacation and get in a car accident, motorcycle accident, boating accident, who have these life like altering injuries. So summer can be kind of heavy for those of us who are in places like that where you work too, and it's really hard to compartmentalize. Um,
Hmm.
and how would you say for you that affects more of like your personal life other than like vacation and turning off your phone and all that? Did you find that it was affecting relationships?
Oh, absolutely. My children's dad and we split up, just from everything. The burnout for me was really severe. I was not taking care of myself. I wasn't interested in doing anything. It really rolled into like a severe anxiety depression for me. And it took, around the time we were splitting up, I was diagnosed with type 2 diabetes at the same time.
Mm,
And so just looked at everything, and I had to make some changes. So I really started focusing more on myself, my well-being, working out, taking walks. I started, that's kind of when I shut down my blog for a while because I was so burnt out on dysphagia at that point that I didn't even want to think about it for a single minute of the day. And so I actually got my certification in nutrition coaching. during that time, because for me, my biggest thing was to take care of my health and get my health back in check, but to not do it with medication.
Mm-hmm.
I did not, I told my doctor, I'm not going on metformin. You're not doing it to me. You're not giving me any kind of statins. I'm not doing any of it. And so, I had a certain timeline with her because she knows me too. And she gave me 3 months to make some changes and to start turning things around. And I was able to do that. So fast forward, it gets to be about mid 2024. I'm feeling good. I feel so much better. All my numbers are great at this point. I lost a ton of weight, just more active, taking more care of myself. I started doing diamond painting in my free time. I don't have a lot of free time, but I started making time for the diamond painting. I started making time to go work out, to just have time to myself, and just to, not be trying to be everywhere at one time and doing everything all at the same time. And that's kind of when too, I thought, okay, I'm gonna get back into this whole dysphagia realm. And so I did that, because the good part is with the nutrition coaching, it like goes hand in hand with dysphagia. So
Yeah.
I am so much more valuable to my patients now, because these people that are now, on a very limited diet, we can work on, what to focus on nutrition wise, because we don't have dietitians. So it was a perfect combination, but it also got me out of a rut at the same time.
Yeah, it's definitely a journey, and I think it's and thank you for sharing that because it's very personal. I'm sure it's not easy. Um, whenever we're talking about our personal life and our our health journeys, it's really important, I think, for people, other clinicians, to hear that and to know that
Mhm.
um you're not isolated, you're not alone. A lot of us have had health challenges and things like that, and um it's important to share it because if you're experiencing it, it's the same thing we tell our patients all the time, right? If you have a
Mhm.
question, I'm sure, or I tell my students, if you have a question, ask the question because someone else in the room has the same question or something similar. And if you sit there and you're too afraid to ask it, or, when it comes to patients and caregivers, they often feel like no one's listening. And if
Mhm.
you say, hey, what questions do you have? And you really give them that time and that pause to ask those questions, I think they are so much more appreciative because you feel seen and you feel heard. And we think of that a lot of times, I think, in terms of our students and our patients and caregivers, but we don't think of it in terms of ourself.
Right.
We can't
Right.
care for anybody if we're not caring for ourselves. And I think that was one of the things that really came about in the pandemic, is people were saying, "Oh, you have to self-care. You have to self-care." And everybody was like, "What the heck does that mean?" Like, I don't know what that means. I come home and I take a shower. I made food for my family. Like, what's self-care? What does that
Yeah.
mean?
To me, self-care is just, taking 5 to 10 minutes even just to do something you enjoy doing. Some people like to color, some people like to journal, some people like to go out in nature and walk. You know, Self-care is just doing something you enjoy. It could be taking 10 minutes to tell everybody in your house to not talk to you. Give me 10 minutes. I don't want to hear a single voice, and I'm going to go lay in my bed for 10 minutes and just just chill out. I just need to regroup, and then I am all yours.
Mm-hmm.
But, it's definitely, finding what works best for you, for your family. For me, I went down to 4 days a week. I work 4 days a week. So I get a 3-day weekend every weekend, and it has been life changing for
Mm-hmm.
me. Um, and I think that our companies need to think about this too. When we start burning out, when we start not caring, we start making a lot of medical errors.
Mm-hmm.
We don't listen as well as we should. And we start getting patient complaints, patient satisfaction significantly decreases. And we are now in a world of the value-based purchasing where we have to have that star rating. So, so yeah, we have all of that. It's harder for us to maintain those safety protocols, which,
Mm-hmm.
not only damages our patients, but we can hurt ourselves doing that. So, it's a priority, and you show up better at your job when you are happy, when you are satisfied, and when if you've done your red light face mask or whatever it is that you like to do, you show up better at that job and you can do a better job. I think one thing that I have prided myself on recently is patients telling me, you're the only person that has listened to me and let me
Mm-hmm.
talk. And that just means a lot because I know how many people they've dealt with.
Mm-hmm.
And I know I saw it pop up in the chat about ASHA needing to deal with that. And I agree. I don't think ASHA supports us um, like they should. I'm probably very well known for not liking ASHA. I'm not a fan. Um, I hope that doesn't affect the continuing education.
No, I mean, I know a lot of people have varying opinions. I'm on the
Yeah.
probably more on the opposite because I know I was the president of our state association in 2020,
Mhm.
and it was the probably the worst year to be president of anything. And a lot of feedback I got from people afterwards who were not involved in any shape, way, or form with our state organization was one, they thought I got paid to be the president of the state organization, which was hilarious because I did not. Um, the amount of advocacy and legislative issues that are hard to prioritize. I had a whole different
Hmm.
like I have a whole different perspective because I was in a different role. So I think
Right.
I agree that there are ways that we could be more supported in that. I will say that I was happy that um, it was just so weird this whole thing that happened recently with the CF and not being able to bill.
Yeah.
That was not new. That was not new. That happened in 2015. That was 10 years ago. And people were freaking out about this whole clarification. And then they wound up, ASHA did lobby for that to be fixed, and that was fixed. CMS did fix it. So that's good. But I think, again, it's sort of knowing if you're not going to be a loud voice in a squeaky wheel,
Hmm.
that's because it's the same with management at our healthcare facilities and our schools.
Oh, yeah.
A lot of people will like say things behind the scenes, but they're not going to the people that are stakeholders who can force change or make change, or they're dealing with a boss who's just a piece, for lack of better words, who isn't going to support them. And so I
Right.
think that it's like weighing which way are you going to go, and kind of understanding the system because it's not a perfect system. And I think that that trickles down for sure. So I can be on board with that. Um, but yeah, I think just looking at systems that are in place that are broken, and that's systemic from insurance reimbursement, um, people who are in management who aren't qualified or who think they know what you do and they don't because they're not billing the same way that we do. They're not documenting the same way that we do.
Right.
And um, so I think it's a bigger issue than just one entity or the other because I see it across several different entities. And it's one of the reasons why, like in my practice right now, I'm not doing insurance because it's a pain. And
It
I'm,
is.
just starting the private practice, I don't want to go into it that way. I want to go into it
Hmm.
and be able to treat patients the way I know that they need to be treated. I want to spend the time with them. If they only need 30 minutes, they only need
Hmm.
15. It's like a lot of our dementia patients need a touch up or a tune
Right.
up, as I call it. They might just need a couple sessions a week to reinforce use of their compensatory strategies or support their caregivers. And then other people are new and they might need 2 hours for an eval. And
Yes.
it's nice to have that autonomy and be able to do that um, without someone sitting there going, well, you weren't 100% today. You had green time on your schedule. What did you do to fill it? Did you go to
Yeah.
the doctor's office downstairs and ask for a direct referral? And I'm like, what are you talking about? Like, this is not, it's not how this works. And then like for you being in home health, drive time, you're in a more rural area, which I worked in a rural area for a long time too. And it's like, oh, you don't have enough patients today. You should go to the bigger hospital 40 miles away. How am I getting paid for that? Am I clocking in to the new place while when I leave? Do I also get mileage? Like,
Hmm.
it's all the things.
Yes. My drive time has definitely is more than my patient care time at this point.
That's insane.
But yeah, we got to the point we cover 9 counties now, and we go like halfway into Indianapolis. So we're very rural, but then now we're going into, our major city. So, and it's road construction season and back to school and, farmers, and we get hit.
Yeah.
And yeah, and and I would agree, I really think that we need to start with I think our organizations need to start in supporting us,
Hmm.
and I do agree, I feel like ASHA, and I feel like especially in the healthcare sector, in the medical, we don't always feel as seen, I think, by
Hmm.
ASHA, but I don't feel like the school people feel seen either, and it's hard when you don't feel like you're seen.
Yeah.
We really don't have a lot of support to fall back on to, talk to, or, hey, what do you do in this situation? We just don't get that a lot because we're also overworked and overbooked and burnt out for real.
Yeah. Yeah, and it's a great point too, because I think one of the things that we have always talked about advocating for is salaries, because no other job, when you have a master's level degree for entry, are you making the kind of poor cash that we're making.
Mm-hmm.
And, compound that with student loan debt, um, the economy and things like that. That's another way that a lot of
Mm-hmm.
our early career professional clinicians get burnt out and they leave. They leave the
Mm-hmm.
field. And that's crazy when you think about it, because you've spent 6 years at minimum getting this degree, and then probably, in your first 5 years, you're trying to get certified in things, right? You might be looking, if you're acute care, you're trying to do fees, you're trying to do MBS IMP. Maybe you do want to get board certified in swallowing or language. I did certified brain injury specialty my second year out of school. You're trying to
Yeah.
do these things to make your skill set better and more marketable, but at the same time, you're not getting paid. Did you get an increase in your salary when you got your BCS?
No,
That's
not one bit.
no, me, yeah, no. And I see it online all the time. People are like, oh, when I get my C's past my CF, am I going to get a salary increase? And I'm like, probably not. Probably not.
Just
No.
takes you longer to document because it takes you longer to sign your name at that point.
Yeah, yeah, for sure. Um, and I think again, you know, and I say this because I'm in Virginia and I worked with someone on our state board for years who did a lot of behind the scenes work for caseload caps, and she made it work in her county.
Mm-hmm.
They actually did a lot of the things that she recommended, and it did become something when she became our seal, our, I always get this wrong. It's an education person basically for the state who's a liaison for our state education system to ASHA for SLPs. And she did actually have some momentum for caseload caps. And in some places,
Mm-hmm.
it was a caseload workload was the verbiage I think they were using. And again, I'm not school system, so I don't understand all of the ins and outs of caseload versus workload. And it's Amber Handon is her name, and she's actually working at a university now. But for years, she did all these like really cool graphics and like
Mm-hmm.
presentations and things like that. And I think for those of us in healthcare, people were attempting to do the same thing. But the other part of that when it comes to ASHA isn't just ASHA, it's states. Each state has their own licensing guidelines. They have their own
Mm-hmm.
qualifications on what you can do, their own practice portals on things. Like I know for us, we had an issue come up well, it's been more than a couple years ago, but um, a neighboring state, their SLPs can do um, suctioning that goes down that's beyond the trachea into the
Mm-hmm.
lungs. Well, for us in our state, it's respiratory therapy does that. So there was a lot of chatter and talk, and people wanted to do position statements and things like that. But there were a lot of pieces legislatively and position statements by our state board, or not our state board, but our licensing board that were already in place that said, this is who does this and this is who does that. And so there's a lot of places where, um, there's necessity and then there's licensing. And it does vary from state to state. And that makes it hard for things like caseload caps and practice regulations when you're thinking that we're all doing it the same, but the state has more control when it
Mm-hmm.
comes to the state boards of practice, not the state board as far or the state organizations. It's more the licensing boards have these regulations and these requirements that are they're different from state to state. I know for me, Maryland's completely different than Virginia, and I did a talk about ethics a few years ago, and even looked at like bigger states like Texas. They have a lot more statutes and things like that than we have in Virginia, and then you have smaller states population wise like Maine who don't have nearly the regulations that we have. And so that part is a challenge too, because it's not just ASHA, it's the states that vary from licensing board to licensing board, which is why interstate compact came up to begin with, which is a whole nother topic than burnout. But when we're advocating for things like that, that also leads to our burnout because we're like, oh my God, you can't see the forest for the trees,
Yeah,
right?
and I feel like no matter where we work, we're always expected to cover more than one building. You know,
Mm-hmm.
whether it be in the schools, in the skilled nursing facilities, sometimes even the hospitals, we're expected to go see so many people in so many different buildings. And, you never get like that sense of teamwork
Mm-hmm.
because you're working with different staff in different buildings, and they're there all day and you're just running in and trying to grab your people and hoping that they're not like in the bathroom or eating lunch or, physical therapy doesn't have them sitting in the circle with a big group of people kicking their leg. You're constantly like, you're always in that fight or flight
Mm-hmm.
mode no matter what we do because we have so much to do. And then, we got to get home because my kid has to be picked up at school at this time. And then they've got practice and then they've got games. And, we're constantly on the go and we just have such a hard time stopping and slowing down.
Yeah.
And And that very much contributes to you just get to a point where you're like, I don't want to do anything because there's
Yeah.
so much to do.
Yeah, and I think you did a nice job talking about some actionable steps when it came to, you know, setting some boundaries with your workplace and your coworkers and office staff, and then also making sure you had time for yourself. But are there other things that you feel like we should be doing or could be doing as clinicians where we're actually taking an action so that we protect ourselves, protect our license, but also protect our patients?
Right. And, I feel like definitely just talking over with your direct supervisors, that something has to give because I know in healthcare, it is every single day that we are drilled into our heads about patient satisfaction. One of our things is because on our surveys that are sent to our patients, their families, if they don't mark some of our things, so we're to use the word definitely. Like they will, when we do meetings, all we hear is the word definitely because they're trying to drill it into our heads to start saying it. So just talking to your staff that your supervisor that look, I'm getting really burnt out and I am definitely not going to be getting a good satisfaction survey report here because my patients are noticing. I
Mhm.
walked in and worked with Mrs. Johnson and she said, boy, you look really tired today. What's going on? And I'm supposed to be the one working with her. She's not supposed to be the one being my therapist. So, you can't show up to your job and you can't do your job well if you are to that point of burnout that you just are just struggling. And I think, until we stand up for ourselves, just a little bit at a time, it's just never going to change. And I feel like, and I just remember watching, especially in the skilled nursing facilities, the level of productivity requirements just going up and up and
Yeah.
up. And, I think it started out at like 75% productivity. And then, it gets up to where I've seen people have to be like 110%.
Yeah, we were
How do you
100 in acute care.
yeah, I mean, how can you be, there's no possible way to be 100% productive
Well, there's a chart.
because,
There's a
yeah,
chart that tells you how to do it, but
yeah.
it's
And I
not.
mean, but, and technically, if you think about like you're walking and doing paperwork at the same time, but still billing the patient because, yeah, at least for us, productivity is patient care time, and that's all that matters is that patient care time, that time that is actually billable. But
Mhm.
they don't take into account the fact that I've got to call 100 hospitals to find out where this person had their swallow study and then try to get that report, or that I've got to prepare for the session. I've got to read the person's chart, and for me to sit in a person's house and read their chart, like, oh, hold on, let me flip through this 89 pages on my phone and see and see, if I can find any speech notes, which, 90% of the time they were never included anyway.
Yeah.
But, I think our burnout starts with we've never really been the important therapy
Hmm.
until somebody can't swallow or can't speak. And then we're, just, oh my
Number
gosh,
one.
I'm so happy to see you.
Yeah,
And
my old boss used to say that she was a PTA by trade, and she'd say, uh, "I don't care about PT. I want OT so I can go to the bathroom, and I want speech so I can eat." And she
yes.
said it all the time in staff meetings, and we all joked about it and laughed. But uh, she did recognize the value of what we do, and I'm not quite sure why that's ever become a we weren't the important ones.
Hmm.
Because I know in some places I've seen our colleagues, and it's not always in just bigger metropolitan areas, but there's some places where people have advocated for speech or their managers have been speech and they've been set up for success. Whereas a lot of us have not been managed by people who recognize the value and we weren't set up for success. And so it's like beating your head against the wall, trying to advocate, but at the same time knowing that, um, from the get go, from the time we're CFs to, being fully licensed, independently practicing SLPs, we need to be setting those boundaries from the beginning. Because if
Absolutely.
we had been taught that and we had been doing that, we would not be in the space that we are now. But I think a lot of us are so type A plus, A plus plus,
Hmm.
competitive. We know that we are competing for minimal jobs in a lot of areas where when I was working in trauma, there were 7, 8 PTs and 1.5 SLPs
Hmm.
in the
Right.
same hospital with 6 buildings. It makes
Right.
zero sense, but we were not set up to be productive and be successful. We were set up to be burnout and fail. And I think that starts with us changing the mindset with our students so that they can help continue this advocacy effort and, um, you know, at
Yeah.
not only advocating for themselves, but for people who come after them.
And, I think just teaching our value, to our patients, to their family members, to our students, to their family, to our immediate supervisors, and just working up that ladder to teach them that we do have value. We have master's degrees. I know a lot of other disciplines, OTPT, are both going to the doctorate, but we do so much continuing education. I think
Mhm.
we do way more than a lot of people have to. We have so much that we have to learn. And I think just, trying to step and increasing our value as professionals, I think will help a lot with that burnout when, we can actually advocate, learning to advocate for ourselves, um, grouping together. I know there's always people. I've been hanging out a lot on Instagram lately. I really like Instagram. I feel like it doesn't have the same uh, stress that Facebook gives me a lot of the times. And the same level of arguments and fighting that happens in a lot of the Facebook groups. So I have started to prefer Instagram, but just finding some like-minded people that maybe are in the same boat or have been in a similar situation, that you can bounce ideas off of each other and
Mhm.
hey, well, this worked for me, maybe this would work for you. I think just trying not to feel so alone out there will definitely
Yeah.
help everybody too.
Well, and we had a lot of good comments, and I won't read through the webinar chat, but we did have someone who asked the question, how did you inform clients of a change in your schedule? And I'm assuming that means when you went to 4 days a week, and how did they
Mhm.
handle it? And I will say for me, I was PRN and I went to Flexi, and so I think your experience is probably going to be different than what mine was because you
Yeah,
were in home health.
yeah, and I told people I work Monday through Thursday. And so I just told people I'm sorry, I don't work Fridays. Um that's just not an option. So I am able to get the majority of people in Monday through Thursday. I just had to learn to set my areas. So I go to this area on this day. And if
Hmm.
you're not available in that area on that day, I will try to get to you if I can on a different day, but know that I may not be able to see you until next week. And I've just had to set those boundaries because people, will be like, well, I've got to go to Target that day. I've got to go do that. Well, okay, if Target's more important than your speech therapy, then that's not my issue at that point. So,
Right.
I- you know, I've just had to set very clear boundaries. And I just have to tell people, I cannot be my best self. I cannot be at my best for you if my cup is just constantly drained.
Yeah.
And me working 5 days a week with the travel and everything, I was just, I wasn't going to make it much longer.
Yeah.
So,
No, and I agree with that. And I think again, it trickles down a lot and we don't sometimes realize it until we're in that space. And so, looking at those things you mentioned earlier about how you're feeling and really being in touch with yourself and giving yourself permission to do that because a lot of people don't. They're like, oh, I'll just muddle through, I'll keep going, I'll keep trucking along. And
mhm,
so I really appreciate you saying, hey, we need to be having our finger on our own pulse, checking
absolutely.
in with ourselves and not just worrying about everybody else all the time because it doesn't do you any good.
Absolutely.
Well, thank you, Tiffani, so much for being here. Thank you for working through the technical issues as well. I know that's always a challenge, and
Yes, I
um,
was sweating for a minute. So thank you for your patience.
yeah, no, it happens to all of us at times. But yeah, I just really appreciate you being so willing to share your personal story and giving us some ideas on ways that we could try to set those boundaries and be more present so that we can be better clinicians and better humans and continue to advocate for ourselves and our patients.
Absolutely. We all need to do that so much.
So, just as a reminder, if you've joined us for this live episode and your state license requires live CEUs, be sure to complete all course modules, including the one that says complete course before the end of the day on your Speech Therapy PD account. And again, Tiffani, thank you so much, and we look forward to seeing you again.
Thank you so